the Department of Forensic Medicine, and my own department for giving me an opportunity to talk on this stage. And thanks a lot, sir, for the warm introduction. It was a very nice thing to see my UG PG college pictures there. Okay, so sir has asked me to talk about the basics of infertility and how we go to progress to assisted reproduction techniques. So which are the cases who are going to go for ART from the basic workup to the basic treatment, then who goes for ART. So Mrs. A, who is 29-year-old, and her husband, who is 31 years old, have been married for 2.5 years. They have been trying to conceive for the last 15 months, having regular unprotected intercourse but without success. So initially both assumed that it is going to happen naturally, but over the last 6 months she notices that her cycles have become irregular with occasional acne and weight gain. She worries that probably it is the stress or long work hours that is affecting her fertility. Her husband has no major health issues, but he admits to occasional smoking and high stress due to work pressure. So he wonders whether this could affect his sperm quality. The couple finally visits a fertility clinic after family pressure increases. So this is a common scenario that you are going to find when you are going to sit as a consultant in the infertility clinic. So in the next 1 hour I shall be talking about, no clinical workup is complete unless you know the basics. So unless you know the physiology, then the pathology, you will not understand the clinical workup. So we start with the basics of reproduction, the pathology of male and female fertility, how do you approach an infertile couple, and what are the indications, what are the techniques of assisted reproduction technique, and what are the complications and controversies, and a slight touch on the ART and Surrogacy Act 2021. So the standard definition of infertility is inability to conceive after 12 months of regular unprotected intercourse. So this 12 months has been considered because most couples, they conceive at about around 80% of the couples are able to achieve pregnancy on their own by the end of the first year. By the end of the second year, even up to 90% of the couples can achieve pregnancy on their own. So that is why we have this cutoff of 12 months. But in case the woman is already more than 35 years old, or she has, or the female partner or the male partner, either of them has got some factor which might contribute to infertility. For example, if the woman is a known case of PCOS, or the male has undergone some surgery for cryptorchidism. So these we know are causes that might contribute to infertility. So in that case, the infertility workup can be started even after 6 months of marriage. Now we have some terminologies called as primary infertility and secondary infertility. Primary infertility is when the couple have been unable to achieve a pregnancy even for once. And secondary infertility is they have had a pregnancy which might have ended up as an abortion, or there might have been a live birth, but following the primary pregnancy there has been no other pregnancy. So that is primary infertility and secondary infertility. And it has been found that about 10 to 15% of the couples are affected with infertility globally, and surprisingly the prevalence of infertility in both developed and developing countries is almost similar. And if you look at the trends of infertility these days, there is a slight increasing trends towards infertility, and it has been found, especially with male infertility, there is a moderate increase, and probably this increase is because of the infertility rate has been going down because probably of the increased work stress, PCOS, increased incidence of PCOS, the change in the lifestyle factors, substance abuse. So these might be some of the factors which are contributing to the increasing trend of infertility. Now let's look at the causes of infertility. If you look at the causes, we find that both the male as well as the female can contribute to infertility. So female factors are contributing in about 30 to 40%, while male factors may contribute to another 30% combined, where the male and the female both might have a contribution of about 10 to 15% unexplained infertility. That is, both the male partner and the female partner are found to be absolutely normal. So the semen analysis is normal, there is no identifiable female factor, and still they have infertility, and that may account for another 10 to 20%. Now coming to the basics of reproduction, one has to first understand about the hypothalamo-pituitary gonadal axis. So everything starts from the brain, right? So let us look at how it is in the male. Sir, I am not able to point. So the hypothalamus secretes the gonadotrophin releasing hormone, which stimulates the pituitary gland to release two hormones, luteinizing hormone and the follicle stimulating hormone. So this follicle stimulating hormone is going to act upon the Sertoli cells in the seminiferous tubules of the testis, resulting in spermatogenesis. The luteinizing hormone will stimulate the Leydig cells in the testis, resulting in secretion of testosterone. Now testosterone is a male hormone which is essential for the secondary sexual characteristics and for spermatogenesis. So this feedback has to work properly in case of males. Now coming to the females, the hypothalamus secretes the gonadotrophin releasing hormone, which stimulates the pituitary to secrete the FSH and the luteinizing hormone. So the first part of the ovarian cycle is dominated by the follicle stimulating hormone, while the second half of the ovarian cycle is dominated by the luteinizing hormone. So this follicle stimulating hormone is going to act upon the ovary and cause follicles, multiple follicles to be developing on the surface of the ovaries. Now these increasing follicle number is going to cause an increase in the estrogen levels. So this increasing estrogen levels is going to give a negative feedback to the pituitary, and that will decrease further levels of FSH. So the decreasing FSH levels is going to cause an atresia of the follicles. Only one follicle is able to respond to low levels of FSH and develops into, what is it? What does it develop into? The Graafian follicle or the dominant follicle. Okay. Then the positive feedback of estrogen on the pituitary causes an increased secretion of the luteinizing hormone, and this luteinizing hormone is, when it becomes LH surge, it is associated with rupture of this dominant follicle some 36 hours after the LH surge. Okay. So following the rupture of the follicle, the ovum is released into the peritoneal cavity, which is then picked up by the fallopian tube, and the corpus luteum is formed from the Graafian follicle. So this corpus luteum is going to secrete progesterone. So this is the feedback mechanism that is taking place in the female. Now coming to the male reproductive system, you will have a separate talk exclusively on male infertility. So I am not going into the details of it. I am just going to touch upon this because this forms the basis for what I am going to further talk on assisted reproduction techniques. So I will just talk the minimum that is necessary for us here. Okay, so the males have a pair of testes which is placed in the scrotal sacs, and the scrotal sacs are lying outside the abdominal cavity, and the scrotum, nature has seen to it that spermatogenesis requires around 2 to 3 degrees Celsius lesser than the normal body temperature. So the testes have to be placed outside the anterior abdominal wall in the scrotal sacs. Now spermatogenesis takes place in the testis. So this, I am not able to point it here. The pointer is not.
He has gone to take the pointer.
Okay, right. So the spermatids are. Yeah. Okay. Thanks. So as I told you, these testes are placed in the scrotal sacs so that the temperature is around 2 to 3 degrees lesser than that of the normal body temperature. So this is what is optimum for spermatogenesis to take place. So sperms are, the spermatogonia which are produced in the testis are collected in the epididymis. Now the epididymis is like a cap on the testis which collects these sperms. The sperms that are being produced in the testis are immature, and in the epididymis there is some amount of maturation that is taking place. So from the epididymis, the sperms are transported through the vas deferens, where it joins the duct of the seminal vesicles to form the ejaculatory duct. Now this what you are seeing here is the prostate gland. The ejaculatory duct joins the urethra and at the level of the prostate, and it comes and joins the penile urethra. So the glands of the seminal vesicle and the prostate and the bulbourethral glands, these add on to the secretions, and this ultimately forms the semen, which contains both the seminal plasma and the sperms. So during sexual activity there is erection of the penis and followed by ejaculation of the sperms. Now coming to the female genital tract, the vagina is the organ which is going to receive the sperms from the male, and the vaginal pH is acidic, whereas the sperms, the seminal plasma, is alkaline. So once the sperms are deposited into the vagina, the acidic pH is an irritating factor to the sperms. So around 100 to 300 million sperms are deposited in the vagina during each ejaculation, and many of these millions of sperms that die because of this acidic pH, and only a few lakhs of it reach the cervix. Now the cervix has cervical mucus which is alkaline in nature, and during ovulation the cervical mucus starts thinning, so which allows the entry of the sperms. During other times, that is when the ovulation is not taking place, the cervical mucus is thick and does not favor the entry of the sperms. So the sperms have now entered through the cervix. After they have gone through the cervix, they enter the uterine cavity. In the uterine cavity, the uterine musculature, the contractions of the uterine musculature helps to transport the sperms. It helps to transport the sperms to the fallopian tube. In the uterus, however, the immune system of the woman recognizes the sperms as foreign bodies, and some more damage to the sperms are taking place. So some more of them are killed, and only a few thousands of it are entering into the fallopian tube. And those that are entering into the fallopian tube are having a very severe competition. Okay, so who is going to be the fastest to reach the ovum? Only the one which is going to reach it first will go fertilization. So when the sperm goes and meets the ovum, there is something called as the acrosome reaction. So following the acrosome reaction, the sperm, the contents of the sperm, they go and enter into the ovum to form the zygote or the embryo. So once the fusion of the nucleic acid material has taken place, now the zona pellucida, which is the outer covering of the ovum, now thickens, which does not allow the other sperms to fertilize. So once one sperm has fertilized, the fertilization process is over, preventing other sperms to fertilize the ovum. So this is nature's way of taking care that from such a stiff competition, so to win over a female there have to be so many males. The competition is very severe. Millions and millions of sperms have to compete for fertilizing one ovum. So causes of male infertility, again I am not going into the details because we have our urologist who will be talking on it, but just touching upon it, we can broadly put it as pre-testicular causes, testicular causes and post-testicular causes, or rather more physiologically you can talk as defective spermatogenesis, a fault in the transportation of the sperms. The semen quality may be abnormal, or there may be a fault in the deposition of the sperms in the vagina. So as I told you, there may be a defect in the spermatogenesis which can be a problem in the hypothalamus, the pituitary, or maybe the scrotal sac is not able to maintain the temperature properly. For example, in case of varicocele, where there is the increased vascularity will cause an increase in the temperature, or the testis has not descended, that's called as undescended testis, called cryptorchidism. Good. So cryptorchidism, where the testes are placed in the abdomen, so that will also affect the spermatogenesis. There can be other genetic disorders. which can affect the spermatogenesis. And exposure to heat, occupational exposure to heat, wearing tight underwears, these can all affect spermatogenesis. Even certain drugs like anti-epileptic drugs, some common antibiotics, or even the proton pump inhibitors, some antihypertensives have also been found to interfere with spermatogenesis. Infections like tuberculosis and a history of mumps in childhood is a very important thing in the male, which when we are working up male infertility, we always ask for whether there has been a history of mumps in the childhood, because it has been found that orchitis can affect, in the early childhood, can affect spermatogenesis in the later stages. Okay. So if the spermatogenesis is affected, maybe we have crossed this level if the sperms are being produced properly, but in the next stage they have to be transported across through the vas deferens. So this transportation may be a problem. So this can happen if the vas deferens is congenitally absent, right? There may be some congenital abnormalities where there might be an absence of the vas deferens, or there might be a blockage of this vas deferens, which may happen as in case of tuberculosis or trauma, or maybe there has been some surgeries in the pelvis, like maybe they have had a hernia repair. So in those cases there can be a defect in the transportation. Now coming to a defect in the semen, now an infection of the seminal vesicles or the prostate is going to affect the quality of the seminal plasma. So seminal vesiculitis or prostatitis can increase the WBC secretion, and remember the seminal vesicles are the ones which are going to secrete, the secretions are very rich in fructose, which is essential for the motility of the sperms. So this is the ingredient which is going to help in the give energy to the sperms for the motility. Okay, so and the sperm production may be normal, but the count may be less, or their morphology might be affected, or there might be a problem in the motility. So the quality of the sperms that is being produced may also be abnormal. Now till here everything is normal, the next abnormality can happen here. So where the deposition of the sperms in the female genital tract may be not possible. For example, in case there is, as I told you, sexual excitation will cause erection. So some of them may have erectile dysfunction. Premature ejaculation, that is, ejaculation has taken place even before penetration into the female genital tract. Or retrograde ejaculation, where the ejaculation has gone in the reverse direction and gets collected in the urinary bladder. So these are some of the disorders. So penile ulcers, which might make it painful. So some of these causes are known to lead to male infertility. Now coming to the causes of female infertility, going back to this picture, you have to remember that the causes can be vaginal or cervical, could be uterine, tubal and peritoneal, or ovarian. So ovarian and tubal infertility are the most common causes for female infertility. If we look at the ovarian factors which are contributing to female infertility, it could be either because the woman has a decreased ovarian reserve. Now all of us know that in utero the female fetus has millions and millions of primordial follicles, but these follicles are undergoing continuous atresia. So at the time of birth, these millions of follicles are getting reduced to only a few lakhs of follicles, and when she reaches the age of puberty, this few lakhs is also getting reduced to few thousands. So only a very few follicles are actually available for reproduction. So this continuous process of follicular atresia will result in a diminishing ovarian reserve. So as the age increases in the females, the ovarian reserve also keeps diminishing. But in some women, inherently also the ovarian reserve may be less, and especially if she is undergoing some chemotherapy or radiotherapy or anything which is cytotoxic, the ovarian reserve can go down. There are also other causes in the ovarian which can result in anovulation. So now, according to the WHO, there are 3 types of anovulation. So you can remember that the hypothalamo-pituitary ovarian axis. So In the hypothalamus-pituitary ovarian axis, the problem can be either with the hypothalamus-pituitary or it could be at the level of the ovaries, right? So if the problem is at the level of the hypothalamus-pituitary, you call it as hypogonadotrophic. The pituitary is the one which is secreting the gonadotrophins. So it becomes hypogonadotrophic, and because of this hypogonadotrophic hormones, the gonads start functioning less. So hypogonadotrophic hypogonadism, which you see in pituitary disorders and hypothalamic disorders. Next is the ovarian cause, which is normogonadotrophic normogonadism. So here you will find you find that the hormones like LH and FSH are normal, estrogen levels are also normal, but there is no synchrony in these hormones, or these ratios may be abnormal. So this is the commonest type we find, and all of you know what is this PCOD. What is it? Polycystic ovarian disease, right? Okay. And next is the type 3 or hypergonadotropic hypogonadism, which means that the ovaries have started failing. If the ovaries are failing, it means that the feedback from the ovaries to the hypothalamus pituitary is not there, which means that LH and FSH are going to be secreted more. So that's why it's called hypergonadotropic hypogonadism. So this is what you find when there is a premature ovarian failure. Next is the tubal causes. The tubal causes, now we know that in the physiology, after the ovum is released, these fimbria, which are finger-like projections, they pick up the released ovum from the peritoneal cavity and transport this ovum across to the ampulla of the fallopian tube. So the tubes, either it might be that there is a congenital absence of the tubes, or it could be that these tubes have a partial or a complete block. Please remember, in India, tuberculosis, gonorrhea and chlamydia are 3 notorious organisms that can cause pelvic inflammatory disease and tubal damage. Uterine causes like fibroids, Mullerian anomalies, endometrial polyps, and Asherman syndrome. Asherman syndrome is where there are intrauterine adhesions between the anterior uterine wall and the posterior uterine wall. So these can all again interfere with fertility. Now immunological and cervical causes are another 5% contributory. Now this might be because of an anatomical cause, like there might be a cervical stenosis or the cervix is short. Now I told you the cervix has to produce the cervical mucus, and the quality of the cervical mucus should be good. It should be alkaline, good enough, thin enough for the sperms to allow penetration. So any abnormality in the cervical mucus or an anatomical problem in the cervix can lead to infertility. And immunological cause, this is a very important thing, the anti-sperm antibodies. Okay, the anti-sperm antibodies in the cervical mucus may kill some of the sperms or can affect the motility of the sperms. There might be other causes like peritoneal causes where endometriosis is multifactorial. It can affect the ovarian, the tubal cause, or it can produce infertility in multiple ways, and there could be pelvic adhesions which might interfere with the pickup of the ovum. Other causes in the lower genital tract, there could be vaginismus, some painful lesions of the vulva, vulvovaginitis, vaginal septum. These can also interfere with fertility, and even stress, anxiety and depression have also been found to interfere with female fertility. Now coming to the evaluation of infertile couple, again I will not be going too much into details of this because we have experts talking about this. So when we come for the evaluation of the infertile couple, it has to go parallel for both the male and the female partner. So detailed history is what is very important. So when it comes to the male partner, you have to also ask about whether there are any coital difficulties, what is the frequency of coital activity, whether they are aware of the fertile period, and whether there is any history of premature ejaculation, or whether there is any erectile dysfunction, what is there any history of smoking, alcoholism, substance abuse, what is the occupation. So these are, and the past history of tuberculosis, any surgeries. So these are some of the histories that you will collect for the male. And in the female, again you will take a detailed menstrual history and any other contributory factor that might lead to infertility. So examination, especially you look for any evidence of polycystic ovarian disease, like look at the BMI of the person, whether she is obese, whether there are any features of acne, hirsutism, or any other evidence of insulin resistance. So these are some of the specific things that you look for in both the partners, and a detailed gynec examination should be done for the females. And in both the partners, we are going to do basic routine investigations, which includes complete blood count, blood sugar, VDRL, HIV, HbSAg, and a urine routine examination. In the male partner, we start with semen analysis. Evaluation of the male partner, it becomes very simple. That if the semen analysis is normal, no further testing is required. Now, semen analysis has to be done according to the guidelines given by WHO. Again, we have an expert talking on it, so I am not elaborating into it. If the semen is abnormal, then we repeat the semen analysis after 1 month, and if it is still abnormal, then it is time for us to refer to the male reproductive expert. I am not going too much into the semen analysis again, but because you have to, we will be talking about ART and introduction of ART. So I'll just tell you what are the things that we look for in the semen. You have to look for the pH, the volume of this semen, the total sperm count, the motility of the sperms, the vitality, and whether the sperm morphology of the sperms is normal or not. So there is a slight variation in the 2010 and 2021 guidelines. So the parameters have a little improved because of an improvement in the ART techniques. Again, here I am just touching upon it because we will be using these terminologies when we are going to talk about ART. So aspermia is when there is no semen. Aspermia is no semen, not no sperm. So aspermia is no semen. Azoospermia is no sperms in the semen. Okay. And actinozoospermia is when the motility is abnormal. Teratozoospermia is when the morphology is abnormal. Oligospermia or oligozoospermia is when the sperm count is less. A combination of oligoactinozoospermia, also known as OATS, is when all the parameters are subnormal. Necrospermia is when we find there are too many dead sperms. So how do we evaluate the female factor? Ovarian factor, the most important evaluation and the most practical one is follicular tracking with transvaginal ultrasound. Should I wait? Yeah. No, sir, it's okay. I'll continue. I'll just. No.
Live YouTube நல்லா போயிட்டு இருக்குங்க.
Okay.
Somebody is sitting in the department, they are watching.
Oh.
Live clear போயிட்டு இருக்கு.
Okay. Nice, sir. Nice arrangements.
அது credit goes to Gopi.
Oh.